Good morning and welcome to the Baker Institute. I'm Ed Gereggian. I'm the director of the Baker Institute here at Rice University. I want to welcome you all very warmly and congratulate you on getting up so early. There's plenty of coffee out there, and my doctors tell me it's good for your health. This tremendous presence of all of you here this morning is really a tribute to two things. One, our speaker, but also I think the criticality of the issue that we will be addressing this morning and in the future. As some of you know, the Baker Institute has a broad agenda in both foreign and domestic policy. Today we're here to focus on a key domestic policy issue, health care. A Harris poll conducted in September 2007 showed that health care is second only to the war in Iraq as the most important issue Americans want our government to address. In the realm of health policy, U.S. adults list health insurance coverage as the top priority they want our government to address, followed closely by concerns regarding the rising cost of medical care. This sentiment is certainly no surprise to all of you in the audience, given that the U.S. expenditures on health care exceed $2 trillion per year and account for 16% of our GDP. Despite these high expenditures, or perhaps because of them, 47 million Americans now lack health insurance coverage. This is a soft underbelly of our society that needs to be addressed. The Baker Institute Health Economics Program has taken an active role in addressing these and other health care issues. The Health Economics Program's mission here is to study the ways in which economic incentives and government policies influence the quality and the costs of health care. The program's guiding philosophy is that society can deliver high-quality medical care while controlling expenditures. Healthcare providers, patients, and others must be offered incentives to balance costs against benefits to ensure that resources are not wasted. No existing health policy research center focuses on the effects of incentives embodied in institutional arrangements. This program is directed by our Dr. Vivian Ho, the Baker Institute Chair in Health Economics. She's also an associate professor in the economics department here at Rice University and in the Department of Medicine at the Baylor College of Medicine. Dr. Ho and her colleagues' research has led to important findings regarding disparities in the distribution of specialist physicians in the United States and resulting inequalities in access to health care. She has also studied the impact of state certificate of need regulations for cardiac care, an issue which has obviously important implications for the debate on the role of specialty hospitals here in Texas. In addition, the Health Economics Program is studying the potential role that high-volume cancer surgery centers can play in improving the quality of care and restraining costs for cancer patients. I am very pleased to inform you today that this year at the Baker Institute we are also launching what we're calling the Health Policy Forum. This will be akin to what we've done at the outset of the Baker Institute in establishing the Energy Forum, which has become one of the leading research directions of the Baker Institute and now has worldwide presence. So we are launching this year the Health Policy Forum, which will offer a unique setting for medical and policy professionals to discuss the major challenges facing our healthcare system. The forum will facilitate the exchange of ideas in order to spur groundbreaking research and policy decisions and to foster improved understanding of national and regional health concerns. Look for the forum to provide a comprehensive analysis of the proposals put forward for health care reform by the 2008 presidential candidates in our upcoming Baker Institute Presidential Campaign Issues series, which will run up to the elections in 2000 through 2008. Let me now ask Vivian Ho to introduce Dr. McClellan, no stranger to the Baker Institute. You were here in the early days, I remember, Mark, who will provide us with his perspective on the challenges facing our healthcare system. Dr. Vivian Ho.
Thank you, Mr. Ambassador, and thank you to everyone for coming here this morning. It's a pleasure to have the opportunity to introduce Dr. Mark McClellan to you. When I first met Mark, I was a brand new assistant professor at McGill University, and Dr. McClellan was doing his MD PhD he was doing his PhD in economics at MIT and his MD at a joint collaborative program between MIT and Harvard. I met him at a conference. Tell you the truth, I didn't think much of it. I thought, oh, this is another one of these wannabe students who wants to get both the degrees and sort of look really important, things like that. And, sort of didn't think much of it until what happened is he published his dissertation coming out in the Journal of the American Medical Association in the 1990s on the application of a technique you may not have heard of, instrumental variables, to analysis of health policy issues. And it was an incredibly high-impact, important methodological and sort of a health policy conclusions came out of that paper. And to this day, health economists all over the country continue to use this method, and it's become extremely helpful to us in our analysis, and I use it in my research today. And so Mark, being the modest kind of person he was, continued to publish up this storm when he was at Stanford, all sorts of high-impact papers, and they were great. And he never told anyone that he has this wonderful political background and experience. So it was a bit with kind of puzzlement. We thought, okay, he goes to D.C., but then he becomes commissioner of the FDA, and we thought, wow. And then following that, it had a tremendous impact there, and then went on to become the administrator for the Centers for Medicare and Medicaid Services. And during this time, it was wonderful to see such a talented health economist apply his skills to these particular institutions. So I remember him for actually pushing through in the FDA and encouraging faster approval of novel drugs for the American people. And when he was at Medicare, many of you would read the paper and saw that he was brought over to introduce Medicare Part D and the prescription drug benefit into the country. But at the same time, he was also a wonderful supporter of getting quality report cards for nursing homes and hospitals out to the American people, and a great supporter of pay-for-performance initiatives as well. So I think he will go down in history as being one of the most influential people in terms of improving the health care of just the common American citizen, and you will see that in the years to come. What's so exciting about Dr. McClellan is that he's still so young, and he's still so innovative, and so you're going to see he's going to have a tremendous impact on healthcare policy for many years to come. And so it's such a pleasure to have you here, and Mark, and we'd love to hear your comments.
Thank you very much, Vivian, for that extremely kind introduction. I do feel a little shy about all of this, but it's a real pleasure to be back here at the Baker Institute in Houston. In the audience today, I've got family members, I've got old friends, and I've also looking around the room, a lot of the leaders in healthcare in the Houston area, in the state of Texas, and people who are nationally prominent as we all work together to try to deliver better care and greater efficiency in our healthcare system to address that core challenge that Ed Jerigian mentioned in his opening remarks. It's also a real privilege to be part of the Baker Institute's activities. As Ed said, I go back to some connections here, back to the very early days when this initiative was started, and it's been a real privilege to see how much of an impact the programs here have had on good economic and policy analysis of practical relevance here in the region, in the nation, and all over the world. And I have very high expectations of the expanding work led by Vivian and others in health policy that's going on here at the Institute. It's really a terrific and promising program. Not only that, when I've been here for the last day or so, I had a chance to catch up with a lot of my colleagues at the medical center between UT Houston, MD Anderson, and Baylor. Houston continues to lead the way in healthcare innovation and delivering better cures to Americans and people all around the world. And so really you all are in a unique position to address some of the challenges that our healthcare systems face, and you have had sort of first-hand experience in trying to lead the way in doing that. You know, on the one hand, that we are continuing to develop better treatments that are leading to prevention of complications of diseases, heading off diseases in the first place, longer and better lives for Americans. In fact, economists who have looked at the the issue of what we're getting for what we're spending in health care have come up with some pretty impressive results. So we are now living about 8 years longer in pretty good health than we did less than half a century ago. And that is tremendously valuable. In fact, according to some independent economic analyses, the value that's created for living longer, living better, is worth more than the improvements that have come in every other sector of our economy combined. Jet travel is great, iPods are great, all of that's terrific, but what's really valuable is having the time to enjoy all of that, as well as the sunsets and the time with family and everything else that makes life so wonderful. And that's what healthcare and biomedical innovation have done. But as you know, as those surveys that Ed talked about earlier show, the reaction of the American public to these improvements in health and to the greater capacity of our healthcare system to improve health has not been one of satisfaction and complacency. It's really a reaction of concern, of anxiety, even of anger, that even if these better cures and better treatments are coming along, people are worried that they're not going to benefit because they may not be able to afford it. So we've got a real big challenge in our healthcare system today, and dealing with this challenge is, I think, one of the core issues for our nation, for the world, for the 21st century. Now, I'm going to go through some ideas, some thoughts about how we can address the challenges facing healthcare, and I'm going to do it, as I talked about, with the leadership here at the Baker Institute, focusing primarily on some examples and experiences that I had in overseeing the Medicare and Medicaid programs, particularly the Medicare program, over the last few years. But as you all know, Medicare and government programs more generally account for a large part of healthcare financing in this country. So as Medicare goes, so goes our healthcare system. And what I'll be talking about in the Medicare context certainly applies to and certainly creates some opportunities for improvement, I think, in other parts of our healthcare system as well. I'm going to try to leave plenty of time towards the end of my remarks for discussion. I know from knowing many of you in the audience so well that this is not a group that's going to be shy even at 8 o'clock in the morning. And I, too, want to thank you all for coming out early. I know, as I was just talking about with John Mendelson, that 8 o'clock a.m. is kind of a midday break for many physicians. But for a lot of people, it's a little bit difficult to get up and get out so early and engage in such a weighty topic. But I want to make sure we have plenty of time for back and forth around these very important challenges in health policy facing our country. So let me start by talking a little bit about the challenges facing the Medicare program, because they're pretty representative of the challenge that we're seeing all around. We're seeing rising healthcare costs, seeing rising frustration, and there will be continuing healthcare policy responses to these challenges. And I don't want to oversimplify, but you can think about the directions that healthcare policy can take, and addressing the challenge of rising healthcare costs is moving in potentially a couple of directions. The final common pathway, when we can't figure out anything better to do, and especially in government programs like Medicare, is to take some broad brush, blunt instrument types of approaches to try to get healthcare costs down. And those tend to fall into two main categories. One is pushing down on the prices that we're paying for medical services. So tried and true approach in the Medicare program, anybody who's a physician in this room knows this, is that if volume and intensity of services go up, which is the main determinants of rising costs in a regulated price system like Medicare, the reaction, if you can't figure out anything else to do, is to cut the prices. In fact, that is built into the Medicare legislation now. If costs go up at a rate significantly greater than the rate of growth of the economy, which has been the case for the last few years, with more kinds of medical treatments, more intensive treatments being delivered, and more people in the program, the result is a reduction in payments. And as of January 1st, physicians in Medicare are scheduled to face close to a 10% reduction in their fee rates for each of their services, because we haven't figured out a better way to focus on getting more effective care at a lower cost. The other approach, the other blunt instrument approach, is to restrict access to services. In other countries, this is called rationing, and a lot of people don't view that as happening so much here, but it does happen here to some extent. Sometimes it happens indirectly by not being able to get covered. Sometimes it happens more directly. Medicare is having some controversial debates right now around coverage for treatments that help raise your red blood cell levels if you have cancer, if you have other conditions that tend to be associated with anemia. And the Medicare program has proposed and is implementing some restrictions on how these red blood cell treatments are covered, with some good reasons. There's some real evidence of overuse and perhaps misuse of some of these treatments, but because you can't implement a very customized approach to getting the right treatments to each patient through any kind of regulatory approach, these tend to be more blunt instrument restrictions that affect broad categories of patients. And the problem with these kinds of solutions is that we are moving into an era in healthcare where medical treatments are getting more personalized, more tailored to the needs of individual patients. So the array of treatments that are available for a health condition is getting more complex, more vast than ever before, and virtually all of these treatments are beneficial to someone. It's just that many patients may not benefit, and many patients, and there's some real gains from trying to customize the treatment. That's why people talk about personalized health care with better information technology and better predictive diagnostic tests based on genomics and other personal characteristics that can match you up with a treatment more effectively. So how is that going to fit with these kinds of policy reforms to try to, these blunt instrument approaches to keep costs down? Well, if we're getting better at targeting treatments to individual patients, that means when a treatment gets used, it's going to be more valuable, not less valuable. So price controls and trying to squeeze down the payments for those services seems like it's moving in the wrong direction. And also, since care is getting more personalized, blunt instrument approaches saying, these types of patients or this population is okay to treat, this population is not okay to treat, it gets harder and harder to get those right because so many other factors that are very hard to take account of and keep up with in any kind of insurance payment rules are factors that ought to influence what doctors, and increasingly influence what doctors and patients should be doing to get the best care for their individual needs. Is there an alternative? Well, I think there is, and that is to try to find policies that help us get at the core challenge in our healthcare system, which is that too often we are not delivering high-value care. So I talked about earlier that on average we're getting a lot for the money that we spend in healthcare, but it's also just as true that there is a lot of money, a lot of resources being spent in our healthcare system that are not delivering real value for the money that we spend. I think this is a core source of frustration. You don't have to look very far. You don't have to be an expert on healthcare to know, as some of the studies here at the Baker Institute have shown, that there are big variations around the country in how patients are treated. Medicare costs vary by 50 or 100% or more from one area in the country to another, with no clear relationship to the results or the outcomes for the patients being treated. Even in hospitals, Dartmouth, some researchers at Dartmouth did a nice study of the quote-unquote U.S. top hospitals, the top 100 hospitals in the country, where according to U.S. News and World Report, which is in turn based on rankings from health professionals and others, people who ought to know, and they found that the cost of care for intensive treatments at the nation's best hospitals also varied by 100% from hospital to hospital, which led Uwe Reinhardt, another health economist, to comment, how is it that the best health care in the world costs twice as much as the best health care in the world? So there are some real variations in costs, and that's not the only problem. A lot of people focus on these problems of potential overuse or questionable use of treatments. There's also a lot of underuse in our healthcare system. Medicare beneficiaries get treatments that have been proven to be effective and we know works and we know should be used. They get them about half the time, 55% of the time. Long-term compliance with medications for high blood pressure and other conditions like diabetes may be as low as 20%. Very big gaps between the kind of health care we ought to be providing to prevent costly complications and help people live longer and what our health care system actually provides. And you all know from the Institute of Medicine report, To Err is Human, that there's tremendous evidence of misuse of treatments in our health care system. Errors in delivering medications, errors in coordinating care that lead to tens of thousands of deaths and billions of dollars in extra health care costs in our health care system every year, year after year after year. These problems are well known. What's proven to be more difficult is finding something to do about it. And so no wonder a lot of the public gets frustrated and gets concerned that they see all this money being spent. They see all these gaps in how healthcare is actually being provided. So no wonder you get some calls for radical solutions and frustration that we just can't seem to get it right. Well, I think there are some promising opportunities to do more to increase value in healthcare, to promote innovation, to get more for the dollars that we're spending, and avoid some of those blunt instrument approaches that I talked about earlier. And I've seen some of this firsthand in the Medicare program. I can't tell you how many physician groups, organizations came to me at some point during my time as administrator with some ideas that they thought were going to lead to better care at a lower cost. Some of the people in this room came and did that. They have some innovative ideas of using health information technology, for example, or for developing better evidence on which of these treatments and which of these approaches to medical practice were really leading to better outcomes for patients. And I can't tell you how often I then took those ideas to our staff who very much believed in the same goal. You know, they see CMS as our Centers for Medicare and Medicaid Services as a public health agency because how we pay can have such a big impact on the delivery of care. And we're frustrated by the restrictions in current law and the restrictions in our current health care policies, which in Medicare very often tend to focus on paying more for more services, paying more for more intensive treatment, paying more for more complications, regardless of their quality or their impact on patient health. Just to give you one example of this, there's some very good ideas being implemented now in many employer health plans around the country at places like Pitney Bowes or Marriott or Safeway, where the employers have decided to take a different look at health care. Instead of just focusing on their health insurance costs as a cost center for the company, they're looking at the overall burden of disease, the true costs of health problems on their employees. And that means looking not only at health insurance costs now and down the road, but also at productivity costs. So if their workers are sicker and worse health, or they're missing more time from the job, they're less productive on the job, so-called presenteeism, those are all significant costs related to health problems. And what many of these employers have found is that they need to think of health and health care in a different way. They need to intervene earlier and help people diagnose health problems early, intervene with wellness kinds of interventions, not traditional types of health care, but steps that can head off the costly complications of heart disease or diabetes, and then redesign their benefits so that they promote better compliance with medications, better education, a lot of stuff that's not traditional ways of thinking about health care as something that you get when you get sick, but heading off the problems earlier on. They're finding that counting costs all in, so not just health insurance costs down the road, but also productivity impacts, also workers' compensation costs, which tend to go up when workers have health problems. They can save money with these kinds of approaches. Well, you can't do it in the basic Medicare benefit because Medicare, as you know, has a statutory package of benefits, very traditional. We just added prescription drug coverage 2 years ago, and it was 40 years in the, as a more standard benefit in regular health insurance. And the standard Medicare benefit package doesn't include this kind of focus on staying well and paying more when you're healthy and paying more when you help keep health care costs down. There certainly are a lot of other factors that influence the way that health and healthcare spending is going in our country, but this is an example of how the way that we pay tends not to promote the most efficient way of keeping people healthy, of getting what we really want, which is better health and longer lives at the lowest overall cost. If you look instead at the trends that we're seeing in this country, it is very concerning. Our risk factors are not getting better so much, particularly obesity. The obesity rate in this country has gone from 17 to 33% in less than 20 years, according to a number of studies that have come out recently. If we had been able to just hold the line on obesity levels at 1990 rates, our health care cost per person today could be as much as 20% lower. Actually, the impressive thing is that we're, despite the fact that these risk factors like obesity are getting worse, we are still living longer lives. Our life expectancy has kept going up. There's some concerns that may not continue, but we are living longer. It's just a very expensive way to get there because we're not focusing on prevention and preemption nearly as much as we should. And you can see the connection, I hope, between what we're getting in terms of health care and health in this country and the way that we pay in programs like Medicare. So what can we do about this? Well, let me spend a few minutes talking about several key ideas. One is doing more to measure what it is that we really want in health care. It's awfully hard to support support something if we can't do a good job of measuring it and creating accountability for achieving it in our healthcare system. And so far, we do a pretty good way of measuring how often you're admitted to the hospital, how intensive your treatments are, how many lab tests you get, but not such a good job of measuring what kind of impact all of these medical treatments are actually having on your health and what kinds of steps actually help you stay healthy at a lower overall cost. Second, there are a number of steps that we can take, especially with good measures in hand, to support better care at a lower cost. We don't have to settle for just paying more for more services and more complications. And third, if I have time, I want to talk a little bit about developing better evidence to support medical practice. The vast majority of medical practices in this country, at least weighted by what we spend on them, dollar-weighted medical practice, are not well understood in terms of evidence justifying which patients really benefit. And if we are going to move into an era of more personalized medicine, you really need personalized evidence to help people make good decisions with this greater accountability around quality and cost to actually achieve improvements in quality and cost. Now, a lot of this may sound like, gosh, when's he going to talk about coverage? Isn't that what's the number one issue on Americans' mind? And what are we going to do about the uninsured? Well, I think the problem is not in this country that we aren't spending enough on health care. We are. We're just spending it in the wrong way. And if you look at the candidates' proposals from virtually all the presidential candidates, of course, they all are going to say something about getting to universal coverage, or at least getting to affordable insurance options available for everyone. But if you look closely, every single one of the candidates and their platforms for this coming election cycle, and this is more true than I think it has been in the past, every single one of them put front and center a discussion of improving quality and improving efficiency in our healthcare system. This was true for Hillary Clinton's plan, for example. She did 2 major addresses on how she was going to deal with improving quality and reducing costs, reducing inefficiency in healthcare before she even talked about her coverage reform proposals. It's true for the major Republican candidates who have a lot of discussion around how they want to use choice, competition, more of a free market approach to health care to get greater efficiency in the way that people are choosing how to use medical services. It's front and center for all the candidates because no one has enough money to cover all of the uninsured and to make insurance affordable for everyone in the current way that we're delivering health care. We're at 16% of GDP already. According to estimates from CBO and elsewhere, to cover the uninsured, you may need another $100 billion, $150 billion a year currently, and that's going to keep going up if we keep on our current trajectories for health care spending. Some people have said, well, let's just roll back the tax cuts for the very wealthy, but those tax cuts are actually scheduled to expire already under current law in 2010. The big fight that we're going to have politically around tax cuts and around taxes in 2010 or whether those taxes continue. Not only that, they don't raise that much money. Each 1% increase in the tax rate for the very wealthiest Americans raises about $6 billion a year. That ain't enough to fill the gap that we've got in affordable coverage. So every presidential candidate has in their proposal some major elements around trying to get to more affordable health care. And I think that is a recognition of the reality that if we want affordable care for everyone, we aren't going to be able to do it by spending more and more money. We're going to have to find some ways to increase value in our health care system along the lines that I'm talking about today. So how can you do it? Well, one key step, I think, is starting with getting better measures of what our health care is actually delivering. And there are a lot of efforts underway now to do this. There have been national efforts like those from broad-based collaborations like the Hospital Quality Alliance and the AQA, the Ambulatory Care Quality Alliance, and others supported by a group called the National Quality Forum. And the idea here is to try to get all the different key stakeholders in our healthcare system together behind a good understanding of what it is that we want our healthcare system to achieve. And this is harder than you might think because if you look at the health of a patient, there are many things that influence their health other than the health care they get. In fact, that's one of the sort of key points about health policy. If you really want to improve health, you got to look at a lot of other things. Population health, you got to look at a lot of other things besides the kind of health care that's being delivered. Health care is very important, particularly for people with risk factors, particularly for people who have serious illnesses, but sorting out how much the health care being delivered is influencing their results versus other factors is difficult. So most of these efforts to measure quality generally start with what are called process of care measures. Did a patient get the right drugs when they were admitted to the hospital with a serious condition? Did a patient with a chronic disease like diabetes or high blood pressure get medicines that we know are proven to be effective? Were there proper screening tests done and things like that? And that's an important start, but we need to go further. What patients really care about, obviously, are the results that they get. What's the impact of the care on their outcomes? And, very importantly, what is the overall cost of care that they receive? And there now are initial efforts to try to develop those kinds of measures. In the Medicare program, we've moved from having hospitals get paid a little bit more for reporting on some process of care measures consistently around the country based on these standardized kinds of approaches that have been endorsed by a broad range of healthcare stakeholders, to now reporting on an initial set of outcome measures as well. So not only did the patients, not only measures like how well did you do on patients with heart attacks who are admitted to your facility in terms of best medical practices like giving beta blockers and other drugs, but now what were the survival rates at 30 days for the patients admitted to your hospital for a heart attack and for some other conditions. And looking ahead in the next few years, you can see that this will extend to other kinds of measures like complication rates after surgery, maybe longer term survival rates for chronic diseases, and other complication rates like preventable hospitalizations avoided. So more measures of outcomes coming. Another very important element of looking at results in healthcare is patient experience with care. I think this is particularly important for people with chronic diseases who often know more than just about anybody else about what really works for them in terms of keeping them well, keeping their chronic disease from progressing. Next year, Medicare will start reporting on a consistent set of patient experience with care measures for all the hospitals in the country. These are measures like did your doctor and nurse teams explain to you why you were receiving the treatments that you got? How was your handoff to post-acute or post-hospital care handled? A whole set of standard questions like this that will provide, I think, some important insights about how well care delivery teams at institutions are delivering care that patients really find effective. So those are the kinds of outcome measures that I think are going to get increasingly important. Now, hospitals are a little bit ahead of other types of other components of our healthcare system in this, but there also are programs underway that are hitting some initial startup bumps in the road for physician quality reporting, for home health. Vivian mentioned nursing homes, and all these areas. The more that we can make progress on getting valid information about what we want these types of care to deliver out there, the easier it's going to be to create accountability and to move towards a healthcare system that really does reliably deliver better care at a lower cost. And also, it's important not just to think of these measures in silos like we do now. There's some hospital measures and some physician measures and so forth. But really trying to get to the whole experience of care. I mean, after all, what patients really care about is not just whether that the hospital did this and the physician did that, but whether they were all working together well to get the best results for their overall health problems. Going along with the outcome measures, we also need better measures of costs of care. And again, these are starting to be created now, and I don't mean just publishing a list of all the thousands of services that you get when you get sick, when you go to the hospital, when you go to the doctor, not just a list of what the doctor's fee was and the lab test fee was and the anesthesia fee was and the per diem in the hospital was, but rolled up, what you really care about is the overall cost of care for your condition. We need to do a better job of providing that kind of information in a more standardized way so that patients can compare that as well, and so that providers can find ways to see how they're doing relative to other ways of practicing, other competitors. This kind of work is continuing as well. In fact, today, a little bit later today, after I finish this talk, we're doing a press announcement about a new collaborative effort that the HQA, the AQA, some of the other quality alliances, and a steering committee that I co-chair across all of them will be starting to produce measures of quality from a broad range of private health plans and Medicare data so that we can get a more comprehensive picture of exactly these kinds of quality and cost issues. So this is happening now. It is going to keep moving forward. And the faster we can do it, provided that we're doing it right, the more support we're going to be able to provide for health care to deliver the kind of care that it should deliver. Better quality, lower overall cost. Once we have better measures of quality, or as we get better measures of quality, it opens up some new directions for healthcare policy and healthcare financing to support the real healthcare reforms that we need. You know, a lot of people think of healthcare reform as something that happens in Washington. That's not right. Healthcare reform is something that happens in the way that care is delivered all over this country. It's led by healthcare providers and the patients who are working with them. All you can do in Washington is change the policies to hopefully support the good kinds of healthcare reforms. And as I said, one of the things that's impressed me tremendously as I go around the country and have had opportunities to work on these issues is how many good ideas there are from health professionals, from the patients who are working with them, about how they could get better care at a lower cost, but the current policies frustrate them. They get in the way, and I talked about that earlier. So we can do something about that, especially if we have better measures of quality and cost of care. Some of you who are familiar with these health policy issues may have heard the term pay for performance, and the idea is that you pay more when you get better results. Some of these kinds of programs are being implemented around the country now. Medicare's had a few demonstration programs where basically hospitals or physicians get paid a little bit more when they document that they're getting better care in a number of dimensions. I think those kinds of programs are nice, but I'm not sure they go far enough. More promising, I think, are bigger reforms that give healthcare providers what more of them seem to want to take on these days, which is the opportunity to to implement more fundamental reforms in how they deliver care that gets better quality and a lower cost. What do I mean by that? Well, over the last few years at Medicare, we implemented a broad range of pilot or demonstration programs that were founded on the principle of shared savings. And I can't tell you how many doctors or physician groups or hospitals came in with this kind of idea. They said, look, we want to do something different. We want to use electronic health care to email with our patients so they don't have to come into the office and so they can head off complications earlier and more cheaply. We want to hire nurse practitioners to spend time on an ongoing basis with our highest risk patients who are frequent flyers in our offices and frequently getting admitted to the emergency room, because we think that this hands-on care and education support can help them stay well and stay out of the hospital. We want to implement new coordinated approaches for our surgical teams. You pay the surgeons separately from the way you pay the hospitals, and whenever we try to do things together, Medicare says no, you can't commingle those funds. That's against the anti-kickback rules. But what it does, it gets in the way of setting up surgical teams that can work well with the rest of the hospital staff to prevent complications during surgery and to keep patients from getting readmitted to the hospital and to coordinate care better with the post-acute and recovery services after patients leave a hospital. We want to do all of these things, but your payment systems don't let us. Well, the idea behind shared savings is that you can. So in these programs, there is some accountability for the organizations that want the change in payment, but it works something like this. If you document that you can get improvements in quality of care, whether it's preventive measures for the broad population you're treating, or if you're treating certain kinds of patients with more severe illnesses, surgical patients, patients with cancer, things like that, if you can document improvements in their care, process of care, and ideally outcomes, and you can also document reductions in the overall cost of care to the Medicare program, all in, not just physician services, but hospital as well, you can share in most of those savings. So there's some new kinds of accountability there around quality and overall cost, but to the extent that healthcare provider groups can improve, can implement, I don't care what they do to get to the better care, they are able to share in those savings, which does not happen in the current Medicare program. If you take steps to invest in IT or keep your patients well, right now what that means is less billing for your office, less billing for your hospital, and all the savings that might materialize go to Medicare, but you can't do it because you can't still make ends meet in your practice. You need to find a way to solve that problem. Well, one example of this kind of shared savings approach is the physician group practice demonstration, which is now in its approaching its third year for a number, about 10 large multi-specialty group practices around the country, where they were willing to make the kind of deal that I just talked about for shared savings with Medicare. They've been tracking how they're doing on overall preventive care for the populations of patients they serve. These are groups like University of Michigan Clinic, Marshfield Clinic, Geisinger in Pennsylvania, that have hundreds of doctors and thousands of patients. These are large groups, and they have been seeing that CMS recently released the first year report on this program, which showed significant improvement improvements in quality in all of the sites and higher patient satisfaction. Not surprising, because the doctors are now, and the institutions are taking steps to do what patients really want that also can potentially save money. And all of these groups, or almost all of these groups, had some savings. Two of them, even the first year, had more than 2% savings off expected Medicare trends, and that was enough to give them some significant payments back for the savings that they were able to achieve. All of these groups are going forward with their participation in the program, thinking that over time, as they are able to establish these better processes of care for their patients with chronic illnesses and see some of the benefits of better screening and early intervention, that the savings are going to get bigger. So we still need to keep monitoring how well this program is doing and actually achieving savings. But it's an example of how, if you realign the way that our payment system works and our support system works, we can free up, we can create some real opportunities to improve care and let doctors and health professionals get paid for what they really want to do, which is getting better care for patients at a lower cost. I've talked about some of the steps on provider side reforms and payment reforms in programs like Medicare. Before I concluded, I wanted to talk a little bit about another powerful force to get to better results in health care at a lower cost, and that's involving patients or consumers in a much more effective way, giving them choices and giving them information that they can use to choose how to get the care they need at a lower cost. And I'd like to illustrate that using some of the experiences we had over the last few years with the implementation of Medicare Part D. That's the new prescription drug benefit in Medicare, which I think most everybody in this room has heard about. You may remember, as Vivian said in the introduction, this was why the main reason I came to CMS in early 2004. Back then, it wasn't at all clear that this Part D thing, that this was going to work out at all. You all may remember that if you look at the surveys of that issue, it was the benefit after it was passed by Congress. It was a pretty partisan environment. It was not regarded very positively by the public generally, or by seniors in particular. Most health insurance plans thought that it wasn't going to work. How can you provide insurance for prescription drugs only? I mean, what could be a more predictable kind of expenditure? That's when competitive insurance markets really tend to fail. That's when you get the selection problems and you can't maintain a stable program. And there was also a big debate about, hey, it's really going to cost a lot more than what the administration was saying. I remember all that too. So probably not the most auspicious beginnings, but I got over to CMS, and what we found was a staff there that really wanted this program to succeed, that were frustrated that Medicare had been so behind this key part of providing health care coverage that is more prevention-oriented. And so we set ourselves about implementation with three main goals in mind. One was making sure that seniors were informed about the program. Another criticism was that nobody was actually going to sign up. If you look at voluntary enrollment programs for other types of retiree benefits like pensions, you do much better if people have to opt out rather than opt in. Well, we didn't have that option. They had to voluntarily sign up, so we knew we needed to provide good information to help people get enrolled. We also knew that we were going to need to make this benefit work for a very broad range of people in the Medicare program, which range from people who are 65 or maybe even 85 and completely healthy, out playing tennis or golfing every day, vacationing and so forth, who hardly needed any medicines and expected to stay that way for a while, versus some of the most complex and frail patients in our healthcare system with multiple chronic diseases and very high prescription drug needs. So we want to make that work. And then third, we want to bring this program in under the projected budgetary costs. And now we've got almost a couple of years of experience, and the program certainly hasn't worked perfectly. There are certainly some opportunities for further improvement, but in terms of the main goals that we had, things have worked out pretty well. At this point, well over 90% of people with Medicare have prescription drug coverage, so the vast majority of people who didn't have coverage before did find out about the program enough to enroll and make a decision to get into it. Second, if you look at satisfaction surveys of beneficiaries in the program, there have been a whole series of independent surveys done. They're running quite high. J.D. Power and Associates had satisfaction rates of close to 80%. They do all these other consumer goods, and that's actually at the high end of the surveys of the day. It's not the very highest. Turns out the very highest J.D. Power rated product is new cars. I didn't know that before. before. You learn these things as administrator, but pretty close. And interestingly, some of the highest satisfaction rates were among people who had previously been getting their drug coverage through Medicaid, the so-called dual eligible, some of, again, low-income, frail Medicare beneficiaries who previously were in government-run coverage and who were finding that they were getting access to more medicines and were satisfied, were mostly satisfied with or had the highest rates of satisfaction with the program. So again, still some room for improvement, but looking, the satisfaction rates and access to drugs overall look pretty good. In fact, the surveys of overall drug use by seniors show some big increases, particularly among seniors who didn't have coverage before. And then finally, with costs, the program has come in, it's now running about 40% under the budget projections that we had back in 2004 when it was initiated. And there are a number of reasons for that. There was less crowd out of employer coverage than people had predicted. We tried to find ways to coordinate well with many of the retiree benefits that some seniors were lucky enough to have. But a big reason and there was also some slowdowns in overall prescription drug spending growth that affected the whole of our economy. But a big reason for the lower costs, according to the actuaries, more than $100 billion of the latest reductions in the projected cost of the program to get to that 40% savings was due to competition and choice. And that's what I want to talk about, is why that happened, why we were able to get to good degrees of satisfaction, high participation, and lower than expected costs. I think one of the key factors was how we implemented the program. We definitely wanted to set this up in a way that beneficiaries would have choice. So we did not require plans to offer a specific defined set of benefits. There are some standards, some guidance that the law provided, but there was also a standard benefit included in the law, but it wasn't supposed to be the only benefit offered. And that standard benefit, you may remember, had a deductible and then 25% co-insurance like traditional insurance, and then the donut hole, and then catastrophic protection against very high costs on the back end. Do you know how many Medicare beneficiaries are in that standard benefit now? Almost none. Some very low-income beneficiaries are just paying a few dollars per prescription, but the vast majority of beneficiaries have chosen plans that did not have that structure. The kind of plan that they chose tended to be plans that have what are called tiered benefits, and the way that those work is you basically get a lot of savings if you're able to find a drug that meets your health care needs. You and your doctor are able to find a drug that meets your health care needs at a lower cost. So people are overwhelmingly in plans that have free or very close to free generic drugs, and generics are just as safe and effective as the brand name drugs, and they're available for an increasing number of drugs to treat common health problems among seniors. And because they're virtually free, seniors have switched to generics in very large numbers. Now, in the second year of the program, over 60% of all the prescriptions filled in Medicare Part D are for generic medicines, and that kind of leads the country, and the U.S. kind of leads the world in the use of generics. There's been a lot of debate about, should there be more price negotiation. The drug plans are negotiating lower prices than had been expected, and that's another reason for some of the savings. But you can get a lot more savings by switching from a brand name drug to a generic drug. That's like 70% reduction in cost than you can by negotiating a few dollars off a brand name drug when there is a generic available. It could work just as well. Then on the second tier of the benefits are drugs where the plans have brand name drugs where the plans have negotiated significantly lower costs, and those will typically cost someone $20, $30 a month maybe, but that's a lot of savings off the usual price of the drug. And then other drugs are covered, but beneficiaries would pay a bit more of the cost for those medicines. So what that means is that compared to traditional insurance, in this kind of benefit, they have an opportunity to save a lot of money if they're able to meet their health care needs with some of these less expensive medicines. And we've seen a lot of switching of drugs without very high complaint rates. Complaint rates are still running well under 1% of beneficiaries. And that has led to, that was one of the main factors leading to lower costs. And there's also been competition around premiums. The premiums, too, are running around 40% lower than had been expected. And CMS just announced the premiums for 2008, which are, again, 40% lower than had been expected. But this drug switching, this engagement around getting your medical needs met at a lower cost, which has been driven by the fact that seniors now have an opportunity to save they wouldn't have in a standard government-designed benefit. We couldn't have come up with a plan and gotten it through Congress that set things up in this way and got to the lower cost. That was a very big factor. The other very big factor was that we tried to set up competition in a way that didn't didn't pay off if you just focused on healthy beneficiaries. This is a main criticism of health insurance generally in this country, and it's an understandable one. If you look around the country, there's a lot of efforts to do underwriting or avoid sicker patients, designing benefits so that they favor the healthy. We tried to avoid that in a couple of ways. One was that the statute enabled people to get a subsidy for their benefits. That tended to make everybody participate. It wasn't anywhere near 100% subsidy, but it helped pay for some of the costs and made it more attractive to healthy beneficiaries who might not otherwise sign up. The other thing that we did was try to make the plans that attracted the chronically ill individuals get bigger payoffs. One of the key steps for doing that was what's called risk adjustment. And the idea behind risk adjustment is that if a drug plan attracts somebody who's 65 and healthy and doesn't need very many medicines, that's nice, but Medicare is not going to pay you very much money, not a very big subsidy for taking care of that beneficiary. On the other hand, if you attract somebody who's 85 and has 4 or 5 chronic illnesses, or somebody with HIV/AIDS or a very costly cancer that has much higher projected or expected costs for their drug needs, Medicare would pay that plan a lot more. Risk adjustment of payments. And that, I think, has been a very important factor. It's not perfect. We can't predict very accurately everything that's going to influence people's health care costs, but it has been enough to get rid of a lot of the pressure on adverse selection that would otherwise take place in this very competitive individual insurance market where there's a lot of heterogeneity in the risks of the people enrolled in the program. By the way, the same thing is true now in the Medicare Advantage programs. These are the competing private health plans in Medicare that provide not just drug coverage but all medical services, and now include not just HMOs but PPOs and health savings account type plans and things like that. Some of the fastest growth in those Medicare Advantage programs have been in health plans that are tailored specifically to people with costly chronic diseases and frailty. And the reason for that is that we are paying those plans a lot more money, and paying the plans that just attract the healthy people a lot less. And frankly, the people who have the most to gain from coordinated care and the kinds of additional benefits that these private plans in Medicare can offer are the ones with the most serious chronic illnesses, who often have poorly coordinated care and many preventable complications and much higher health care costs and worse outcomes as a result. So a lot of growth in that part of the Medicare program as well. And I think this provides some lessons for coverage reforms more generally. If we can do this for the Medicare population, which is very heterogeneous, includes some very sick people, but also just because you're chronically ill doesn't mean you can't be involved in your medical decisions and can't be involved in getting chances to save money when you choose better ways to get your care. In fact, those are the people who have probably the most knowledge and the most ability to help drive our healthcare system to deliver care better, care that they want better. If we can do it for the Medicare program, I think it's possible to do competitive coverage reforms in other parts of our healthcare system as well. And this is behind some of the ideas in Massachusetts, behind some of the ideas in other states that are setting up purchasing pools for people who don't have good coverage options through their jobs. They're looking at things like risk adjustment and other steps to make these competitive markets work better. And this is a critical role for government. And just to wrap up on this point, if you think about what the federal government ought to be doing, if I just grabbed any of you on the street, I think you'd probably say that our first priority in federal spending ought to be taking care of people with limited means who can't afford health care on their own, to get them into mainstream quality care just like every other American. And second, to provide some extra help for people who have high health care costs, for those with the chronic diseases. This is an area where we ought to be concentrating our resources. This is not exactly the way that federal subsidies work today. We spend over $2 trillion a year on health care in this country. So again, we're spending enough money. But if you look at where the government subsidies go, the Medicare program itself costs close to $400 billion, and most of those subsidies go to people who are not poor, so middle-class, wealthier individuals, and they definitely need some help with their health care costs. But you have to wonder a little bit when their benefits are being paid for by payroll taxes for working families making $40,000 a year who can't even afford health insurance themselves, if this is the best way to arrange the government subsidies. And the other big expenditures are Medicaid, which is over $300 billion a year, and that's targeted primarily to people with low incomes and limited means, and something a lot of people forget about, which is the tax expenditures that we make through the employer health insurance deduction. That is an unlimited deduction, and most people don't know this, but is by far the largest tax expenditure, the largest foregone taxes in the entire tax code of this country. The second largest is the tax deduction for home mortgages, which is a cap deduction. It's got a cap on it, unlike the employer health insurance deduction. That costs about $70 billion a year to the federal government to provide. Do you know how much the employer tax deduction costs for health insurance? If you count payroll taxes, state taxes, and the like, it's over $240 billion a year. It's huge. It's a tremendous amount of money, and it is very regressive. It's concentrated on people with higher incomes and higher tax brackets who have the most generous plans. And again, not that they shouldn't get some help with their health care costs, but when we have a government policy where as much of the subsidy goes to families with incomes over $100,000 as goes to all the much larger number of families with under $50,000, and we're spending about $50 billion in this tax subsidy for those two groups, you have to wonder if that's the best way to prioritize federal subsidies. Now, these are challenging issues to deal with, but if you put all this together, finding ways to take steps to improve value in health care, like I've outlined, finding ways to take steps to concentrate the support that the federal government and state governments are providing on people who really need it the most, I'm pretty optimistic that we can get there to more affordable health care that is innovative and that continues to fulfill the tremendous promise of biomedical innovation in the 21st century. Now, a lot of people are skeptical. This is a tough issue, tough politics. We're about to have a big veto fight around children's health insurance starting, I think, today. And it may make you think that, well, this isn't going to work out. But I'm really an optimist, and that comes from, not just seeing the fact that people can work together in Washington and solve some of these problems, and in states around the country and in communities that are trying to take on these challenges. It can happen. It's difficult. But really, there's so much at stake that the opportunities for innovative, personalized, preventive health care in this century are just tremendous. I mean, this is going to be one of the main shining lights of our economy, of our entire economy for the remainder of this century. There's so much possibilities we haven't tapped into yet in terms of personalized medicines and biotechnology and nanotechnology and other products that just haven't even had any real impact on healthcare yet. And there's too much at stake for our healthcare policies to fail. So it may be an ugly process. There will be a lot of bumps along the way, a lot of politics, but because so much is at stake, we will find a way to get there. I think the challenge for all of us is finding ways to engage, to work together so that we can solve these problems as quickly and effectively as possible. Your leadership is critical, and I especially appreciate all your time with me today. Thank you very much. Thank you. Thank you. And we've got some time for questions, and since I know many of you here, I know this is not a shy group, so please ask questions. Let's see. I'll just call, maybe start in the back there. Yeah.
Osteoporosis.
Microphone there.
I thought my voice was loud enough.
I could hear you fine.
An example of this is in osteoporosis prevention. This country spent $18 billion on complications of osteoporosis. It is one of the measurements they're using for effectiveness of your practice, yet they just cut $100 off the reimbursement. Well, it's almost impossible to do this. You're losing money by the time you figure all your costs. So I think that we need to have more attention to the insurance companies providing preventative care. And my second comment, and the first one is anecdotal, I'm sure. The second one is the pharmacy industry has taken an awful beating right now. They spend billions of dollars on trying to find drugs. Half the drugs do not come to market. I was at Lilly not too long ago talking to one of the scientists, and he's been there 16 years. Now, one of his products had come to market yet. I'd probably change jobs, but he was staying there, and the millions of dollars they're spending, yet the patent runs out, the generics come on. Who's going to support looking for new drugs for, diseases that we have for better medical care. And
Sure.
I'd love to hear your opinions
Well,
about
let me
both.
take the second question first. I didn't have time to talk about it today, but Congress did just pass with a strong bipartisan vote. So who says you can't do bipartisan major health care reform in this country? A very important FDA reform bill last week, and the President signed it last week. That's gotten the most attention around things like the new steps that it's going to take on drug safety and creating what I call an active surveillance system in this country where we can learn a lot better about how drugs are being used in actual practice and risks and benefits in particular kinds of patients once they're on the market. But what wasn't highlighted in a lot of the press is that this also creates a new opportunity for industry to collaborate with academics and the FDA regulators on on developing a more scientific process for product development. And you're right. I mean, the number is actually worse than 50%. It's only about 50% of the drugs that make it to phase 3 after you've invested probably $100 million that make it to market. Earlier on, the success rates are much lower. The average time to market is 13 years plus. So with those kinds of costs and that kind of uncertainty and those kinds of delays, no wonder our drug costs are high. No wonder our healthcare costs. No wonder we're not getting as much progress on medical innovation as many of us would like. This new legislation creates bipartisan support and funding and a collaborative mechanism for what's called the FDA Critical Path Initiative. It's something we started while I was at FDA, which is dedicated to the proposition that we can develop a more scientific and efficient process for product development through things like biomarkers, through better statistical methods, through better knowledge about what predictive gene markers and microarray results and so forth are going to tell you about which patients are actually going to respond so we can substantially reduce those costs. That's another critical part of an overall strategy to get to a more efficient healthcare system. And I'm sorry I didn't get more of a chance to talk about it today, but it's a great topic. On your first question, you're right that our payments, and this starts with Medicare, are very much focused on treating complications and putting the money into complications rather than heading them off. Even with the Medicare prescription drug benefit, over 90% of Medicare spending today is for treatments related to chronic diseases, and a large part of that is for preventable complications of things like hip fractures for patients with osteoporosis. The points I was trying to make about measuring quality care, measuring value, and focusing on supporting value were really intended to highlight the point that we need to change that focus away from just paying more for more complications and towards supporting doctors for keeping patients well. There have been proposals for medical homes. I talked about the shared savings concepts. I think the main thing that people need to be aware of in approaching these, though, is that they are going to probably come with some accountability, not just paying you more for these preventive services, but some accountability around, okay, did this really lead to lower cost? Did it really lead to better results for patients? And as long as physicians are willing to take on that more direct accountability, and it's challenging because there are a lot of other factors besides your care that influence a patient's outcomes, but to the extent we can do that, we're going to move faster in that direction. It's very, very important points that you raised. Thanks.
Dr. McClellan?
Yeah, so who's got, okay, great.
Thank you.
And if you all could just keep giving microphones to whoever's next, and I'll just go into session.
Yeah, thank you. How important do you think it is for us to try to reinvigorate the public health infrastructure in this nation to accomplish these goals? If we're really focusing on lifestyle issues and preventive care issues, is it even appropriate for us to try to work those into the traditional medical care system, or should we take a step back and look at the way we do that in the community and through the primary care structure?
Sure, I definitely think we should take a step back, and the CDC has, under Julie Gerberding's leadership recently, has highlighted some ways in which we can connect what's traditionally been regarded as public health to where health care should be headed, which is much more of this emphasis on preemption and prevention of disease, and a lot more health care that doesn't look like traditional Medicare, but looks like sort of early intervention, preventive steps, behavioral change, things like that. I think that the emphasis that I try to put in my talk talk on moving more towards measuring quality and especially measuring results of care will help with that. I mean, if the focus is on preventing cancer complications or preventing diabetes complications, one of the best ways to do that is through behavioral interventions. And you're starting to see that in some of the health plans in Medicare and some of the private health plans in Medicare that are competing, as I talked about before, and some of the employer reforms where they are providing wellness services, programs to help people exercise regularly, to take other steps that really do seem to lead to lower rates of complications and lower health care costs. We need to do more along those lines. I also think that there's an opportunity for building a better public health related infrastructure using some of the emerging electronic health care in this country. I mentioned the FDA legislation before. It envisions setting up a public-private collaboration to share summary data on complications from drugs and on drug utilization patterns across all of the traditional health plans, like Medicare and private insurance plans, so that we can get a better picture of what's actually going on in potential drug risks and potential safety problems. So, hopefully we'll be headed towards an era where the public health and health care are more merged, both because we're focusing more on the results for patients, not just the services that they get, and because we're building an electronic infrastructure that can use a lot of the data from our care delivery system to address unresolved public health issues.
Hi, I'm Pat Sulber. I'm Chief Medical Officer for Universal American, which provides mainly Medicare products to seniors, including Medicare Advantage. And first, I want to thank you for a great talk, and second, I want to thank you for all the wonderful things that you helped to put into place in your years in Medicare, because risk adjustment really has changed what health plans are able to do for their members. It's actually brought enough money to be able to do the things that you want to do. My question is, there's a lot of talk about what's going to happen with reimbursement for Medicare Advantage plans, in particular private fee-for-service. And so I'm wondering what you think will happen and what you think should happen.
It's a good question. So there's a number of studies showing that now, because of all the rules that Congress has put in place over the years, the private Medicare Advantage plans are being paid more than beneficiaries would cost if they were in traditional Medicare. I think some of those numbers are a bit overstated. For example, they don't include all the costs of administering the traditional Medicare program. They typically focus only on so-called Part A and Part B benefits in Medicare, and the drug coverage in Medicare Advantage plans across the board is turning out to be much lower than in net additional cost than the standalone drug coverage. I think that's because for a integrated health plan, if you use drugs more effectively, you save money elsewhere in your benefits, and the studies typically don't include that as well. Also, I think it's likely that Congress is going to end up doing something about this scheduled 10% payment reduction for doctors in traditional Medicare. So I think the comparison, at least for 2008, is a little bit artificially big. So if you account for all of those costs, the differences are actually quite smaller. If we're really focusing on value in our healthcare system, though, our first goal ought to be, how do we get overall healthcare costs down while getting better health for Americans? Not, can we shift costs from the government to beneficiaries? How do we get, by maybe even getting them in less efficient care? And if you look at total spending, which is what the government pays plus what Medicare beneficiaries pay, that's lower in the Medicare Advantage program. That's because people in Medicare Advantage now are getting almost $90 a month in out-of-pocket savings because they get more comprehensive benefits and they get more coordinated care, and they're able to avoid some of these costly complications probably. So I don't think we should be discouraged. If there's a population that needs access to coordinated care and these kind of integrated services and innovative benefits, it's the Medicare population. And I think there are a lot of ways to save money in Medicare. I've talked about a bunch of them today that would lower overall costs without shifting costs to Medicare beneficiaries, without raising costs in our overall healthcare system. That's not a sustainable solution. So I think you should be real careful about changes in the Medicare Advantage payment rates. That said, there are unquestionably some private fee-for-service plans that are basically just duplicating Medicare benefits, and that's traditional Medicare benefits. That's not what was intended with the Medicare Advantage program. I think Congress probably will and should take some steps on private fee-for-service in particular. Okay, next.
On Medicare Part D. Oh, I'm sorry.
Yeah, go ahead.
Okay.
And then we'll do one more. I'm not sure how much more time we have. I guess we got time for one more after this. So you two.
Medicare Part D. What was the purpose of forbidding states from negotiating with pharmaceutical companies for lower drug prices and making it illegal for purchase of drugs from Canada at lower prices?
Okay, two different questions. So very good questions, and those came up a lot in congressional debate, both around the bill leading up to the 2006 election in Congress this year. For price negotiation by the government, with Medicare, people have talked more about not the states doing it, but maybe the federal government negotiating lower drug prices rather than just relying on the competing private prescription drug plans. And that a lot of people who ran for Congress in 2006 and 1 ran on the platform that, hey, we think we can get lower prices in Medicare Part D if we have the government come in and negotiate too. And those are the majority of the Congress now believes that. The challenge has been is that they did move forward with some proposals in Congress to do that, to have the government negotiate prices. But what the Congressional Budget Office and the independent actuaries at Medicare said was, look, if you want to have government negotiations save money, you got to do something else besides just say that you want the government to negotiate. You need to give the government the ability to move people to different drugs than they're taking now. That's the way price negotiation works. You need a large number of people. That certainly helps. But what really gets you lower prices is the ability to move market share, to take people who are on one medicine and say that, look, if you don't give me a better price, I'm going to move them to another medicine. So what that means is if the government's going to do price negotiation, it needs the authority to do some additional things, like restrict access to certain medicines or set up a government formulary saying that these are the drugs that we really want people to use. And nobody who supported this legislation, or hardly anybody who supported this legislative proposal, was willing to take that step because people are reasonably happy with their Part D plans. The costs are lower than expected, and they didn't want to be accused of restricting access to drugs for seniors. So there have been some proposals voted on that actually passed the House and that I think it got stuck in the Senate that would have given the government the ability to negotiate, but wouldn't have given the government any of the tools that it needed to actually get lower costs. And so we're going to keep having this debate. My own view is that as long as the Part D program is working pretty well in terms of satisfaction and cost, that it might create more risk than benefits to have the government come in and say, well, you can only get access to these drugs, or this is our standard formulary, or something like that. And that's, I think, where most of the Congress is right now, too, Democrats as well as Republicans. And on the issue of drug importation from Canada, that's something that has not passed in law, but it's something that we've had some experience with over the last few years. I think several points. One is that a lot of the drugs that purport to be from Canadian internet pharmacies really aren't, and people have said, well, maybe you could set up a new regulatory program to make sure that they are, but that's going to have a lot of costs associated with it. In fact, a number of states have tried to do their own versions of drug importation programs, like in Illinois and Vermont and a few other states, and they haven't turned out to be very popular. In Illinois, I think they spent about $1 million on it, and only about 3,000 people used it in the first couple of years. So those programs don't seem to be actually getting much lower prices for drugs reliably to people in this country. Maybe a reason for that is that, first of all, most of the drugs that Americans use are generics now, and they are actually cheaper, significantly cheaper in the United States and in other countries that regulate drug prices through the government because they're competing production and they are significantly cheaper here as a result. And number two is that because of there's not an unlimited supply of drugs in Canada, it turns out that in many cases the middlemen for these internet pharmacies, even the legitimate ones, get a lot of the savings themselves. So once you count shipping costs and the fact that the dollar isn't doing as well internationally as it used to, not a whole lot of savings there. So all I can tell you is that the experience in these programs in states like Illinois has been, I think, pretty underwhelming. So those are a couple of points about your questions.
I'm Aubrey Calvin. I'm a lawyer here in Houston. I've been.
Can you maybe speak a little bit more on the microphone?
Yeah, that better. I've been engaged in the last 16 years in litigation with the major manufacturers of pharmaceuticals over price discrimination and price fixing, which we've found rampant in the industry. And two of the things that we came up with was that the pricing of drugs is anything but transparent. It's almost impossible to determine what the true cost of a drug is. It's hidden by so many rebates and kickbacks and other things that you cannot determine what the price of a drug is. Worse than figuring out what the price of a new car is to the dealer. It's much worse than figuring out the price of a new car to the dealer, I assure you that. One thing that intrigued me, I've always thought that public health was an area where a lot more money could be spent a lot more effectively than it is in one-to-one care. Would you like to comment on that?
I'm sorry about
public health, just pure
public health
food, clean water, clean air.
Yeah. Let me comment on both of those points that you raised. I'll start with the pharmaceutical issues. Traditionally, this goes along with price regulation, but in many parts of Medicare and in Medicaid, prices for drugs have been regulated. They haven't been regulated a very low price. It's been based off a system which I'm sure you're familiar with if you've been involved in litigation, historically based off a system called the average wholesale price, or AWP. And a lot of people think of AWP actually stands for ain't what's paid, because it's based off a list price and not the actual reimbursement for the drugs. In the Part D benefit, Medicare doesn't use AWP directly at all. In fact, one of the reasons I think that cost savings have turned out to be so much bigger than expected is that Medicare set up a website and also set up a 1-800-MEDICARE phone line that hundreds of thousands of seniors used a day, and set up partnerships with a lot of groups around the country so that people could get the final prices that they would actually pay for their drugs in their pharmacy, and also the premiums for their plans, and hopefully a good understanding of what their overall drug cost would be under different plans. And we need a lot more transparency like that. I mean, you should be able to figure out what your drug is going to cost you and what your drug coverage is going to cost you, and know that in advance so you can make an informed choice. I think it's very important to keep moving towards that kind of transparency in all types of pricing in healthcare. And your other point about what really determines health, that's absolutely right. The biggest determinants of overall population health are not our health care. So life expectancy, things like that, are determined by things like education levels, personal behavioral choices, environmental factors, and so forth. Which isn't to say that health care isn't important. If we can take steps through our medicines to help people live longer and better lives, that's worth a tremendous amount. But it is a reminder, as I think the earlier comment suggested too, that if we really want our health care system to work well, we need to forge and promote these kinds of connections to population health and what have traditionally been public health concerns. And I think the best way to do that is to make our healthcare system focus more on what we really want. That's better health at the lowest possible overall cost. And the best way to do that is to measure it better, to create accountability for it, to take steps that directly promote it rather than just paying more for more services. Thank you very much. It's been a real pleasure to be back here with you, and I hope we get to do it again soon. Thank you.
Thanks, Mark, for a very insightful talk, and for letting us know that healthcare reform has a lot to do with what we're doing in this room and how we're going to deliver healthcare. We're going to step up to that challenge, and we hope that Mark comes back and sees how we do in the future in our progress. Thanks for coming today.